Welcome. My name is David Williams, and I'm the chair of the Department of Social and Behavioral Sciences and the Florence and Laura Norman Professor of Public Health here at the Harvard Chan School of Public Health. Today, I am delighted to be here with Professor Daniel Dawes. Daniel is a healthcare attorney and equity advocate working to reduce health disparities via legislative reform. He serves currently as the Senior Vice President of Global Health and the founding Dean and Professor at the School of Global Health at Meharry Medical College. He's also the author of the influential book, The Political Determinants of Health, which introduces a new way to think about the forces behind racial and socioeconomic health disparities. So, Daniel, let's start at the very beginning. What are the political determinants of health, and how are they related to what we talk about much more often, the social determinants of health?
That is a great question, and I am so honored to join you this morning to have this discussion. It's really building upon the work that you have led along with other scholars, looking at the social determinants of health, right? We've talked about the structural conditions in which all of us are born into, we live in, and eventually die in. And I remember having a discussion with David Satcher, Dr. Satcher, who served on the World Health Organization's Commission on the Social Determinants of Health. And I said, I feel like this has been groundbreaking. This is eye-opening about these forces that disproportionately impact, play an outsized role in our overall health and well-being. But there's something for me that's missing. And there is that connection between the social determinants of health and their policy roots, the policy actions and inactions that have led to the structural conditions in which all of us find ourselves in. And so I argue that those really are the fundamental instigators or the causes of these social determinants of health that have had an outsized impact on the health and well-being of communities.
Now, you have written that to understand the political determinants of health in America, we need to go back to 1641 and examine the laws first passed in that year that codified slavery. How did the laws and policies enacted almost 4 centuries ago create the conditions that have led to today's health inequities? And why is it important to talk about that history when we talk about the political determinants of health?
Oh my gosh, that's another great question. So, I could start at 1619. I do believe that's a fair starting point. But I start at 1641 because there has been this refrain about personal responsibility, that you need to get up and pull yourselves up by your bootstrap. What is wrong with you? Personal responsibility, Daniel, you're missing that key. And I say, all right, fine, well, let me go back to when laws were developed, right? And 1641, I start intentionally because it's a period in our history where you had both black enslaved individuals and indigenous populations impacted by these policies that were being developed and negotiated and implemented and enforced over time. And the Body of Liberties was that first law that was created, essentially legalizing slavery. So when the abolitionists, the health equity champions, if you will, were pushing back and saying, wait a second, slavery is evil. You're mistreating our indigenous groups. What is going on? The commercial interests, getting very nervous about maintaining the status quo in their business model of slavery, said, we've got to work with these policymakers right now in the colonies. First, they started in Massachusetts, so interesting, ironic that we're in Massachusetts. And that was the template that was then used by Connecticut and New York and Maryland and others afterwards, legalizing slavery. Well, the abolitionists said, upon interpreting that law, we believe that it never intended to include the offspring of these black enslaved folks. And what did the commercial interests and the policymakers do? They amended the law to make sure it included the offspring so that they would be deemed, for purposes of the law, slaves for generations. And as if that weren't enough, what I find very interesting afterwards was the concerted effort by policymakers then to develop policies intentionally limiting or prohibiting black and indigenous groups from being able to raise their own food. We know that food is a critical social determinant of health, right? And yet you can see how law restricted their access to food, especially healthy food. Then there was another law that was developed, again, this time that prohibited Black and Indigenous groups from being able to earn their own money. We know employment is another critical social determinant of health, but again, we have to go further upstream. You have to ask yourselves, how did they come to be in the first place? What created those structural conditions? Other laws, again, limiting educational opportunities for folks. Laws in the colonies were designed to prohibit Black and Indigenous groups from being able to learn to read and write, especially English. We know education is another critical social determinant of health. And then I could go on, I'll just end with movement. We know exercise, right, is a very important determinant of health, and yet there were laws, depending on the jurisdiction, that limited Black and Indigenous groups from being able to move beyond a certain mile radius. You either had to have passes or you had to have lanterns if you were walking at night. Again, movement is key to life. You can see how policy restricted those opportunities for Black and brown individuals at the time. And those laws were then recycled from one generation to the next. And we wonder how inequality gets under our skins, leading to the results that we see today. So for me, it's so important as we're thinking and talking about political determinants of health to look at them in different buckets. I look at them, I start from I start with the end, with looking at policies, right, and dissecting how those, from a legal epidemiology framework, how have they impacted certain groups. I look at government, I look at the processes and the rules and whatnot to see how have that limited our ability to introduce, right, and pass these policies that would be more equitable. And then going back to the beginning on the front end, how are restrictions, voting in particular, right? Voter suppression and so forth, how have those impacted our health and well-being? We know voting can mean the difference between life and death for many of our communities, and yet when you cut those opportunities, you cut off opportunities for them to engage from the front end all the way to the back end through that entire process, and it does have health implications.
Thank you. That is a fascinating history. But let's shift our focus to the present. And what's the legislation that's driving today's political determinants of health? And as a healthcare attorney and a major figure in shaping the Affordable Care Act, you have a particular clear view of the connections between the law and health. What specific laws and policies are you following right now that could be major forces for good or ill for health in our country and for inequities in health in our country?
Well, we know there's no shortage of laws and policies to track when you are trying to examine the impact of health inequities. But I'll start with what you mentioned, which is the Affordable Care Act. We labored to advance the most comprehensive and reticulated health policy in U.S. history, taking an equity lens. There are 62 health equity provisions in this law. We knew that the easy part, according to folks here in Massachusetts who were involved with Mitt Romney's health reform bill, they said, Daniel, the easy part is getting it passed. The hard part is really getting it implemented and getting implemented well, right? And effectively, according to what you all intended. And so 62 provisions, I mean, when you track the implementation of these 62 provisions, it's so discouraging to see how very few have survived the implementation phase now. Many of them early on were used, right, during the Obama administration by opponents of ACA to, of course, get whatever concessions they wanted out of various bills. So we have been tracking really what's left, some dealing with the workforce. Now those are under attack from a DEI perspective. We have some dealing with the public health initiatives to push for community health transformation. Those, again, some of those were eliminated, but some still stand. So that has been quite an interesting process to figure out what has worked, what hasn't, what is salvageable, what else do we need to do to bolster then and basically go back and reintroduce those that have been gone in this environment. So that is what I've been focusing on in terms of ACA. I've also been looking at policies dealing with DEI at the state levels. If you follow state law, the backlash in Tennessee where I live, we've had no shortage again of bills being introduced in the legislature, and we have had to go into the state assembly to make the argument for why it is important from a health sciences standpoint to allow us to continue with this agenda. That it's not just about Black folks. When we're talking about diversity, equity, inclusion, and belonging, we're talking about all population groups, people with disabilities, LGBTQ individuals, you know, veterans, older adults, et cetera, women's groups and so forth. So it has been an interesting thing to follow what has been happening state by state in that regard. And then of course there are other issues dealing you know, with abortion and reproductive rights that we've also been following to see what the impacts could be from an equity standpoint.
I'm stunned by what you said about the 62 provisions in the Affordable Care Act on dealing with health equity. Why is it that most people in public health don't know that?
My gosh.
I mean, you know, it's like this is...
Well, isn't that a great question? Because then you know...
Just trying to process what I'm listening to.
I guess for me, it's one of the reasons why is, you know, and it goes back to what we encountered in the beginning of negotiations over the Affordable Care Act, which was that opponents were outspending us 15-1.
You're kidding.
Yes. They were spending that to put the bill in a negative light or in a false light. And then, you know, afterwards, that even ramped up more, as you saw. So there have been no shortage of folks who have been happy to throw their money at misinformation, to put things in a negative light. And we have just been struggling trying to, you know, keep up and protect as many of these provisions as we can, much less try to educate folks on what these 62 were, right? We tried our best, but obviously we have a communications problem.
Wow. Communications problem, Amanda. Okay. Now, the legal drivers of the political determinants of health aren't just coming from lawmakers. Right. They're also coming from the courts. What are some of the major Supreme Court decisions that you're watching right now, and how do you anticipate that they could impact public health?
Another great question. So yes, that sleepy branch of government, the judicial branch, has awakened as of late and has been doing a lot of damage when it comes to health equity. Interestingly, with that branch, when it comes from a health law perspective, they've very rarely carved out health rights for folks. Now we see them overturning those very few rights that we've secured by law. Now, today, I have been following the McKesson versus Doe case. This is a case that essentially eliminated mass protests in 3 states, in Mississippi, Louisiana, Texas. And we were hoping the Supreme Court would have heard the case and overturned the Fifth Circuit Court of Appeals. Fortunately, we know that that is a critical element on the front end of the political determinants for folks to organize, to get their issues heard and, you know, debated in a civil manner. But that has been cut off, eliminated for those in that state, and folks at the state level now can use their state laws to really push back on those attempts. The other one for me is the Grants Pass case. When we're talking about social determinants of health, this is a case that originated out of Oregon, and the city in Grants Pass had essentially developed 3 ordinances. One prohibited unhoused individuals from being able to sleep or camp out in alleyways, public roadways, and parks. And the city started fining folks about $295 for the first offense. And then they wanted to, of course, prosecute folks criminally if they're repeat offenders and putting them in jail for 30 days. I mean, we're talking about people who are unhoused, who are struggling in society, and you're going to now hit them even harder when they're down? That makes no sense to me. And so it's unfortunate that, you know, in Oregon of all places, that that city was allowed to push that, and now it's being heard by the Supreme Court. I'm watching that from a housing perspective to see what the court will rule, how broadly or how narrowly will that decision come, and what's the impact that it's going to have on people who are the least among us. So those are a few, and then there are others dealing with, you know, emergency abortions, exceptions to the Dawes case, to see what that might look like for folks, you know, who need that so that they can live.
Fascinating. There's a lot we have to look forward to.
Yeah.
I want to shift to talk about what you're working on now. You've been involved in the launch of the School of Global Health at Meharry Medical College, one of the historically black colleges and universities in the United States. And what you're proposing is the first of its kind at a historically black college university. Why is a global school of public health needed now? And why is Meharry Medical College the right home for that global school?
Great question. So maybe I'll start with why Meharry first, and then. So as you mentioned, Meharry Medical College will celebrate its 150th anniversary in 2 years. Howard and Meharry are the two anchor institutions in the health sciences arena that have survived decades of, let's say, contentious backlash, right? Because of our missions and our efforts to diversify the health workforce. And originally, when Meharry was established, there were 14 black medical schools at the time. 6 of those 14. 14. Okay. And 6 of the 14 were located in Tennessee. Well, what happened after the Civil War and after efforts to dismantle the Freedmen's Bureau Act, which at that time was the biggest health policy, the most equity-focused policy that we'd ever gotten passed in the United States under Lincoln's administration, after there were attempts to undermine it, as soon as they succeeded in 1872, and folks were trying to unravel the gains that were made from a civil rights perspective, there was then an attempt to shut off these black medical schools so there would be limited access to health care. Well, Meharry actually came to be right when most of the black medical schools were closing out. The leaders at the time said, no, we see a great need in Tennessee and in the South to have this college. And so where most of them were closing off, and of course with Flexner coming in, shut the remaining schools. So it was only Meharry and Howard left. And Meharry, was determined to succeed no matter the odds. They created a dental school afterwards, a school of graduate studies, a school of nursing, and so forth, because they recognized that interdisciplinary education was critical in the success of increasing access to healthcare services. So fast forward now, Meharry has had this long trajectory. It's in our DNA for advancing health equity for all population groups. We're the ones, when folks were discriminated, whether you had Jewish scholars, they could come to our schools. They could get educated, they could be trained, they could teach as well. We were the ones who opened up opportunities for many Native American students who had locked out of other institutions. So we have the credibility in that respect. Now, why a School of Global Health? One of the things that we recognized is that there are so many amazing things, so many interesting research, so many ways of looking at health inequities around the world, and we haven't connected those. I recognized after National Academy of Medicine was asked by NIH to revisit the unequal treatment report, and they asked me to do an assessment, a study of interventions over the last 20 years. And as I worked with 29 scholars around the country, we were digging into the peer-reviewed journal articles and the social sciences and medicine, public health, you name it. And it was so sad for us. The majority of them, of course, had not utilized an equity lens, right, at least from what we read. And the majority of them were not successful in eliminating health disparities. And the majority of them focused on at the individual level, right, that downstream level, instead of at the structural level. And as we were looking at that, as we got through COVID-19 and recognized how difficult it was to mitigate the impact of COVID on communities of color and other vulnerable populations, people with disabilities and so forth, it just dawned on us that, if we're not going to do this now, we'll never get it done. We need to unite. We need to harness the power of transdisciplinary collaboration, multi-sectoral collaborations, to get at the root causes of these inequities in our society. And that is why we have now been working diligently to establish a school that will help leaders and scholars navigate political and economic structures, as well as navigate societal structures, right? So they can be more effective as leaders in moving the needle of health equity in a degree that will be meaningful. So that's why we were establishing that.
Amazing. And one of the things that many people do not realize is that the patterns of racial inequities in health are a global phenomenon. Most people know it's an American phenomenon.
Right.
But if you look at the UK, you see the same pattern in Australia, New Zealand, South Africa. You see the same pattern in Latin America. If you look at infant mortality rates in virtually every country,
Right.
the indigenous population or the African descended population have high rates. So it is a global issue, and I think we do need to think of some global solutions and strategies that work.
And I love that too. And actually, one of the other things that we're working on is we've established the Genomics Diaspora Institute. We recognize that when you look at genetic information, the overall genetic information, only about 2 or less than 2% of the genetic information studied come from people of African descent. So we have been on a quest now to work with universities in Africa, in the Caribbean, to unite them so that we can build up this repository so that we can be included in the research as well. So it's another reason why.
We have a live audience listening to us online, and there's a question from the audience that I want to bring to your attention. What do you believe are some of the best practices for navigating health equity conversations with conservative governments and people?
My gosh, something I know about. Having lived in Georgia, when folks said, oh, Georgia, Daniel is never going to ever advance any of this stuff. And now in Tennessee, I seem to be attracted to the fire, right, in the belly of the beast. I love a challenge. So I'll tell you from my standpoint what has worked for us. And I actually had the great honor of working on the Senate Help Committee for Ted Kennedy. And Senator Kennedy always believed that something is better than nothing. And I got to see how he worked with Orrin Hatch, how he worked with Senator Enzi of Wyoming to move, let's say, the Mental Health Parity Act, to move the Americans with Disabilities Act, Amendments Act, and others. And I've taken that, in my advocacy in the South. So for me, it is figuring out what are your turnoffs and what are your turn-ons, and what are you most interested in so that we can start there, right? I just did this with Commissioner Ralph Alvarado in Tennessee. Very major Trump supporter. There are folks who are not pleased with him on the left, and there are, of course, people who are pleased with him on the right. I said, well, he's our Tennessee State Commissioner. We have to have a conversation because in Tennessee, we have high rates of maternal mortality. It's very alarming. We have high rates of asthma among Black community. We have high rates of high blood pressure and cancer and so forth. What are we doing? And we see that too in the poor white communities in the rural areas of the state. So obviously something is going on. We're all the way at the bottom in the low 40s in terms of our health rankings. Surely as commissioner, you want to change that status quo, right? You want to improve in health outcomes. So we have been working with him to understand where he comes in terms of his priorities. He's talked about food security as an issue he cares deeply about. He's talked about maternal health and the family. He said, okay, good, we agree with all that. Let's talk about this. We talked about how we define equity. So we went with our definition. If the word is a turnoff, he says, Daniel, don't come with the R word with me. And I said, what's that? He said, racism. I said, okay, well, let's talk about how we view, racism in healthcare. By the time we were done, he was very receptive to what was discussed. He says, I had not heard that piece about the racist algorithms that were used in healthcare, like EGFRs, right, with the kidney disease. He had not heard of the kidney discard rates of, 8,000 last year for African Americans. And he says, my gosh, why? Why is that going on? I said, well, that's why I wanted to bring up the R word. So he was receptive and he listened, and now we are having follow-up discussions. Have we made any substantive changes in policy yet? Not yet. It takes time to build the relationships, but I think it is important that we start with relationships. That's what we did when I was in Georgia, and I actually came from DC to Atlanta, and Governor Nathan Deal was a congressman and voted no against the Affordable Care Act. In fact, he's the one who prided himself in being hell no on Obamacare. So he said, all right, you've dug your heels in very deep in terms of Medicaid expansion. We know that that is absolutely critical, and most of you have been doing health policy research for which we have, that information now. Thank you, because we can utilize and say, listen, these states that have expanded Medicaid, here are the positive things that are happening across the board. Here are the cost savings that they're realizing because you have expanded Medicaid. So in understanding, how they approach things, in understanding what was preventing him from a political standpoint, we were able to craft, a provision in our appropriations bill to at least allow for the study of expanded Medicaid in Georgia. That would give us the Trojan horse that we needed to then push things even more. So at least from that standpoint, that was really great. The other piece for me is I always think about those who come from a strict constructionist approach to the law. So those who are originalists and textualists for the statutes, the originalists when you're interpreting the Constitution, and then the pragmatists like Stephen Breyer and others. And I'll use this as an example. When we are crafting policy, I'm always anticipating litigation might happen. And, if we were to litigate this bill in court, what would be the arguments for and against it to keep it? And so thinking about those who may be opposed to that agenda item, we've developed our strategy thinking about the different frames in which lawyers and judges might look at the bill, and then we craft the bill according to such to give some, wins to one side and wins to another side. So it's been fascinating how we've worked it that way. That's how we've done it.
We probably have about 2 minutes left with our live audience, but I want to slip in one other quick question from the audience. What are some ways we can influence health policy as healthcare providers? What can healthcare providers do to influence health policy? They're doing clinical work one-on-one with patients. What can they do to influence
I love that question. I love it because I know there has been this movement to say healthcare providers stay in your own lane, right? We saw that with the gun violence, the anti-gun violence movement. There was a push saying, what are you doing, doctors? What are you talking about guns? And asking your patients if they have a gun in the home and so forth. And folks said, this is my lane. I believe that this is the lane of our healthcare providers, of our public health professionals and leaders, because, as I mentioned, the political determinants of health really are the fundamental cause and instigators of many of these problems that we're trying to address. And so as providers, let me just put it this way, when the white coats speak, our society inherently listens to them, right? They have tremendous power and privilege, and they have tremendous trust oftentimes. And so it is important for them to bring up these issues that are causing harm, so they do no harm to the respective patients. So I would like to put in a plug for two organizations, Vote ER, and I know Lachlan and I talked about this earlier, and Civic Health Action, where these organizations have been going around working with the hospitals, working with clinicians to get them to understand, why civic engagement is important, to get them to help us register patients to vote, to understand the connection between voting and their health outcomes, and make sense of it all to their patients. And it has seen an uptick in the number of folks who have started to engage in their communities, in their respective hospital settings, engage. And the other thing that I always remind providers is that when you think about how hospitals and provider groups have used patients and consumer advocates for their own agenda, well, how has that worked, right? It's only increased the disparities. And no wonder we have such mistrust in these communities. However, the hospitals that flip the script and say, you know what, I'm going to work with you to advance your policy agenda, they essentially win in the end. And I'll bring up as a quick example, St. Petersburg, Florida is a city that I've been working with. They created this Health Equity Alliance. And this is the group, if many of you remember, there was a study that came out about Black infant deaths and how when these Black infants were seen by a Black physician, their rates of survival were higher than when they were seen by a white physician. It was very controversial. Well, a lot of the African American folks in that community, when the study came out, and they had always been suspicious of these hospitals in their community, that made them even more fearful. this is what's going when I bring, my loved one to give birth in the hospital. And so they now were trying to repair the harm, and they're trying to figure out, and I said, well, you can't put Band-Aids on this. You have some real and serious, very deeply entrenched issues that need to be addressed with this community that have been happening for decades. And many of these folks were locked out of your health systems, were blocked from getting access to health care. Now you should work with, so they worked, to make a long story short, because I told you I'm verbose and I have such a weakness, but they brought these folks together, the providers, the Chamber of Commerce even in St. Petersburg, the business community, and those who hadn't necessarily had a seat at the table and been champions for health equity. They brought them together, and we started with having these conversations. And conversations to sort of heal and just get it out there, get it off your chest. And then from there to start plotting out, what, based on the data, what were the major health issues that you were dealing with? And then we looked at policy, and the legal epidemiology team that I lead, we got together and we started connecting that then to the policies, existing ordinances that were impacting their health. Then they worked with the mayor and the vice mayor, right, with the hospitals backing it now and others, right, these doctors and so forth, saying, yes, we support that. And we got to introduce new ordinances. And from there, you could see the domino effect. It's led to better relationships, better policies being implemented, and better health outcomes.
Thank you, thank you, thank you. This has been a thoughtful conversation.
Thank you.
Yes, it's okay to clap. We want to say goodbye to our online audience now. Thank you for joining us. If you missed any part of the program, you'll be able to view it on demand on the Harvard Chan School's YouTube channel. Have a wonderful afternoon.
Thank you.